Welcome to this lecture on PET neurology imaging for movement disorders and miscellaneous applications of PET neurology. These are the objectives for this talk. First, we'll start with Parkinsonian and movement disorders. Parkinson's disease is a subcortical neurodegenerative disorder. Typically, it affects the elderly and the cause is unknown. There is a decreased number of dopaminergic neurons in the substantia nigra present with Parkinson's disease, and the disturbances of movement, primary tremor, rigidity, bradykinesia, and postural instability are the hallmark symptoms. So Parkinson's is a subcortical movement disorder. Normally, the neurons release dopamine, which is transported to the striatum. This is where coordinated movements originate from. So decreased number of dopaminergic neurons in the substantia nigra will greatly affect the coordinated movements. So this leads to disturbances of movement, tremors, rigidity. Patients will often twitch. And then Lewy bodies is another important component of that. The remaining neurons contain beta synuclein protein, which is linked to dementia and depression. So some other symptoms of Parkinson's include tremor or twitching of the muscles, instability while walking, depression and dementia. There are a significant number of patients who become depressed, and about 10% will develop dementia. On gross examination, the substantia nigra appears pale, and the histologic characteristics are a loss of melanin-rich neurons and the presence of the Lewy bodies. So this is a patient with Parkinson's disease, and this is showing the substantia nigra in the brain. It does become depigmented as it has a loss of melanin. They have an expressionless face, bent posture, rigidity in their limbs. They'll often make that pin rolling movement with their fingers where they're rubbing their finger and their thumb together, and they will have a shuffling gait. One note for patient care with these patients is they are a fall risk because with that shuffling gait, sometimes they tend to have their foot catch or they trip on their own feet, or because they're not lifting their feet up, it's easy for them to trip on any uneven surfaces on the floor, rugs that are folded up and things like that. It is important when we're talking about movement disorders to talk about the dopamine transporters, or DAT. A result of both Parkinsonian syndromes and dementia Lewy bodies is a reduction in the dopamine transporters in the presynapse. This detects the dopaminergic neuron integrity and degeneration. This is an example of actually a DAT scan. DAT scan is a SPECT imaging study, but FDOPA, which is the one where we assess for Parkinson's with PET, is very similar to that. So I use this diagram to just highlight where the substantia nigra is. So you see right here. In the image on the left, you see it highlighted in blue. The darker blue is the putamen, and then up above that is the caudate nucleus. Huntington's disease is one of the Parkinsonian type syndromes, falls into the same category. This is an autosomal dominant neurodegenerative disease. It's marked by involuntary gyrating movements and progressive dementia. Patients will have atrophy of the cortex, the subcortical nuclei, and most prominently in the caudate and the putamen. Huntington's disease has nonspecific histologic changes that include atrophy, degeneration, loss of neurons, and reactive gliosis. The first symptoms do not appear before midlife, but most patients will become mentally incapacitated by 50 or 60 years old. Huntington's disease affects the striatal neurons in the cerebral cortex, atrophy of the motor cortex of the frontal lobe, and loss of nerve cells. Patients have motor disturbances, dementia, and abnormal behaviors, and they have atrophy, degeneration, and loss of neurons. This is where F18 fluorodopa comes into play. It's used to visualize the dopaminergic nerve terminals in the striatum for evaluation of adult patients with suspected Parkinsonian syndromes. This is very similar to DAS scan with SPECT imaging, but it's slightly different and it's used with PET imaging. We cannot diagnose based on F-DOPA only, so it's very similar to DAT scan in that as well, both of them are used as an adjunct to other tests, and diagnosis cannot be made based on the nuclear medicine scan alone. This is a package insert information for F18 fluorodopa, or F-DOPA as it's often referred to. It is tagged to F18, which is cyclotron produced with a physical half-life of 109.7, 109.8 minutes. The principal photons are useful for imaging, are the dual 511 keV photons. That's actually what we're imaging. And the mechanism of uptake for F-DOPA in the dopaminergic nerve terminals in the brain, the F-DOPA is decarboxylated by the amino acid to fluorodopamine, and it's stored in the presynaptic vesicles of the brain. So the accumulation of F-DOPA in the striatum is visually detected in the PET scan. So what we're actually looking at is once it's actually converted to the fluorodopamine, that's what gets trapped in the cells, and that's what we're actually looking at. Optimal PET imaging is achieved about 75 to 90 minutes after administration of the F-DOPA. And the method of localization is receptor binding because it's binding to the dopamine transporter receptors. So it's used to visualize the dopaminergic nerve terminals in the striatum for evaluation of adult patients with suspected Parkinsonian syndromes. There are no contradictions, no absolute contradictions to an F-DOPA study. However, carbidopa blocks the systemic and peripheral deep carboxylation of the F-DOPA. So it's important to administer that 150 milligrams of carbidopa orally at least 60 minutes prior to administration of the F-DOPA. That way that F-DOPA will be taken up in the, will have increased uptake within the brain. So instruct the patient to discontinue medications for Parkinson's disease at least 12 hours prior to administration of the F-DOPA. Patients should be NPO except for water. Recommended dose is about 5 millicuries. To minimize the radiation absorbed dose to the bladder, it is important to instruct patients to hydrate every 4 hours or hydrate for 4 hours prior to injection. They should hydrate well and void frequently. It is kept at room temperature, expires within 10 hours. And so the normal areas of uptake or normal biodistribution for F-DOPA are really, it's based on the appearance and shape of the putamen and the caudate of the striatum. If you look at those axial images, it actually kind of represents a semicolon with the putamen or the caudate at the top, and the putamen makes that comma shape. So optimum presentation of the reconstructed images for visual interpretation is the transaxial slices where you actually see it making that semicolon or semicolon shape. So determination of whether the image is positive or negative is made by assessing the shape and intensity of the striatal signal and comparing both sides bilaterally. Image interpretation does not involve integration of the image with clinical signs or symptoms. So this is a normal scan over here on the left, and then it increases. I'm going to jump all the way down to stage 3, where you see a significant loss. I do want to point out that it will look slightly different in some patients. Some patients you see it really only on one side, and maybe one side of the brain isn't as bad as the other. So seeing it asymmetrically is just as much of a problem as if you see decreases in the putamen or the caudate. Patients must have nothing to eat or drink except for water for 4 hours before administration. To minimize the radiation absorbed dose to the bladder, patients should be well hydrated and void frequently. They need to void at least 70 minutes after administration of the F-DOPA and as frequently thereafter as possible for the next 12 hours. It is important to do a pre-medication with this test. Patients will receive carbidopa. The carbidopa blocks the systemic peripheral decarboxylation of the F-DOPA and increases the uptake in the brain. So to administer this, 150 milligrams of carbidopa is given orally at least 60 minutes prior to the administration of F-DOPA. The technologist should instruct the patient to discontinue medications for the treatment of the Parkinson's disease for at least 12 hours prior to administration of the F-DOPA. So no Parkinson's medications, but we want them to have that carbidopa. So this is a visual representation of the fluorodopa protocol. First, it starts with administration of 150 milligrams of carbidopa orally, and then about 60 to 120 minutes later, the patient is injected with 5 millicuries of F18 F-DOPA over a 1-minute period. Should be injected slowly over 1 minute, should not be given as a bolus. Then the patient will uptake for 80 to 100 minutes, and the patient is encouraged to hydrate. They will void before being placed on the scan, and then you can sedate the patient if necessary in order to get that movement to stop. These patients can sometimes be difficult to scan because they do have those abnormal movements and tremors that they can't control. So work with the patient. Sometimes patients know tricks to get their tremors to stop. And if you just communicate with your patient, make sure they know the importance of holding still and see if there's anything you can do to help them hold still for the study. You'll get better images. And so sedation can be is possible if necessary. And then you'll scan the patient for about 20 minutes in 3D mode. So in figure 1, it's a negative scan. And then in figure 2, it's different variations of positive scans with progressing in severity from A to C, with C being the most severe. Now on to other brain PET CT indications and emerging technologies. This includes psychology, addiction, brain injury, and the use of PET in criminal defense. So one of the things that PET imaging can be used for is looking at brain metabolism and how that correlates to certain psychological disorders. Here you see FDG studies with normal brain on the far left. The one next to it, you see decreased metabolism of sugar in the brain of a patient who is depressed. The one in the middle is a bipolar brain, and that's somebody who's having a depressive bipolar episode at the time of imaging. The next one over is a patient who has schizophrenia, and has visual hallucinations. And you see in the patient with schizophrenia, the occipital lobe is hyperperfused, which indicates that that may be what's responsible for the visual hallucinations. And then the brain on the far right is a patient with obsessive compulsive disorder. And you see that the metabolism in that brain is a little bit different as well. You have some areas that are hypoperfused and some areas that are hyperperfused, especially in the parietal and frontal lobes. I do want to point out or remind you that the frontal lobe of the brain is associated with poor impulse control. And so that might be part of the symptoms associated with OCD. Mental illnesses and disorders that SPECT and PET brain imaging can be done for are not limited to schizophrenia, bipolar, attention deficit disorder, attention deficit hyperactive disorder, and autism. Those are just a few of some of the research studies that are going on now, or assisting with diagnosis and treatment efficacy for those disorders. For schizophrenia, this is a severe and disabling mental disorder in which people have been known to hear voices due to a chemical imbalance of the neurotransmitters. It occurs during fetal development and presents itself during puberty. This disorder can be treated but never cured. And there are two types of scans that can be done. Structural imaging, which creates a snapshot of the brain tissue, blood vessels, infection, tumor, and damage. And functional imaging, which shows the chemistry and activity measuring the blood flow and the metabolism of sugar within the brain. So schizophrenia imaging with FDG requires giving 5 to 10 millicuries of FDG, imaging the patient 30 minutes to about an hour after injection. Patient is scanned supine, head secured in the headrest, and the field of view over the skull, or covering the entire skull for about 30 minutes to an hour. And then the positive test will show significant uptake in the basal ganglia and decreased uptake in the gray matter. A negative test will show increased uptake in the brain matter and look more consistent with what we normally see with an FDG brain scan. It is very important with patients when you're evaluating them for mental illness or psychiatric disorders that they are kept in a quiet, dark room, no bright lights, no talking. Keep that visual and auditory stimulation down to a minimum so you can get an accurate result. This is another example of a schizophrenic brain. Patient 1, you see more increased uptake in the frontal lobe, and in patient 2, you see more increased in the basal ganglia and the occipital lobe. And this is FDOPA evaluation for schizophrenic patients. The cool thing about that one is it doesn't require as much keeping the patient quiet and understimulated for the uptake period because it's not associated with glucose metabolism. So if patients are unable to do that, then this is a better test for them. This is kind of a map where you see that there is increased dopamine transmitters, and the striata is a lot larger in patients with schizophrenia compared to the healthy volunteers. Bipolar disorder is a mood disorder in which a person experiences manic highs to depressive lows. This disorder is considered genetic and peaks at puberty. SPECT imaging and PET imaging can both be done for bipolar. SPECT imaging has been done for bipolar dating back into the 1980s, but SPECT and PET are used to measure the perfusion activity in the brain. However, the activity can be affected by neural blood flow. And these are images of a PET scan that you see in a normal brain versus somebody with bipolar disorder. ADD and ADHD affect millions of children. ADD is marked by carelessness, daydreaming, and I don't care attitude, whereas ADHD is marked by difficulty paying attention, hyperactivity, and impulsive behavior. Children and adults with this disorder tend to have abnormal nerve pathways that regulate behavior and tend to have irregular functioning of certain neurotransmitters in the brain. With ADD and ADHD imaging, a normal scan will show that normal size frontal and temporal lobes for the age group of the child or adult, and an abnormal scan will show both frontal and temporal lobe sizes are reduced for the age of the child or adult. When SPECT imaging is used, it's used with Ceretec. With FDG, it's about 5 millicuries of FDG, and then the patient is scanned about 30 minutes to an hour after injection. A lot of times the protocols just follow the normal neuro-oncology protocol, doing an FDG brain scan. And for autism, this is a developmental disorder that impairs a child's ability to communicate and interact. Some children with this disorder can excel in visual skills, music, math, and art due to sensory stimuli of the frontal and temporal cortexes. Signs and symptoms tend to reveal themselves around age 2 or 3, and most cases appear to be caused by a blend of the autism risk genes and environmental factors that encourages early brain development. When SPECT is used, the child is injected with ECD or Ceretec, and then their SPECT imaging is performed. When it is done with PET imaging, it follows the normal oncologic PET protocol, where patients are injected with about 5 to 15 millicuries of FDG. And they have the normal uptake time where they are reduced from stimuli and then scanned accordingly. This is an example of a PET-MR with a depressed brain versus a not depressed brain. So on the left, you see normal perfusion and uptake in a patient who is not depressed. And then in the patient on the right, you see globally reduced uptake of the FDG. And that's because it is marked by decreased metabolism of glucose in the brain. PET scanning can also be used to look at the effects of childhood abuse and PTSD on a developing brain. On the left, you see an FDG PET scan of a healthy brain, and notice the areas of red are increased uptake, and the areas of blue and black have the least amount of uptake. And this one on the left demonstrates normal childhood activities, normal childhood experiences, and the fully functioning, normally developed brain. On the right, you see the brain of an abused child. This patient is a Romanian orphan who was institutionalized shortly after birth and received some childhood abuse. It shows the effect of extreme deprivation in infancy, and the temporal lobes, which regulate emotions and receive input from the senses, are nearly missing. And typically in a normal brain, or in all brains at birth, only the primitive structures such as the brainstem are fully functional, and then regions like the temporal lobes will develop in early childhood as experiences wire those circuits. So it makes sense that somebody who experiences abuse and lack of love and attention and things like that would have underdeveloped or underperfused areas of the brain. This is another example of PTSD versus no PTSD. And you can see that there are areas of the brain that just the normal metabolism is slightly different. PET scans have also been used to evaluate the effects of addiction. These are patients that received F-DOPA studies to look at the dopamine transporters and the receptors of the dopamine transporters. So in the top row, you see smoker. I guess in the left, you see smoker versus non-smoker. In the middle one here, you see somebody who is alcoholic, somebody who is obese, and then somebody who has extensive history of cocaine abuse. So the dopamine D2 receptors are lower in addiction. You see the control down here at the bottom, and then the addicted. So the first one is cocaine and then meth. And you see with meth, there's a lot of, I guess, holes is the best way to describe it in the brain, areas of the brain that are not taking up any radiopharmaceutical. And then you see the striatum is very heavily damaged by meth. It's also damaged by cocaine. You just don't see it as much in this image. It's kind of globally reduced. Alcohol and alcoholism will affect it as well. You see the caudate is more highly affected in that patient. And then heroin will also cause a decreased uptake in those dopamine receptors. These are really old images, so the image quality looks a little bit different. But image left is no drug use. In the middle, it's cocaine addiction, 10 days without cocaine. And then cocaine addiction, 100 days without cocaine. You see that some areas of the brain start to get more activity back. The bottom one is another F-DOPA scan. There's a normal control followed by a meth user in the middle with 1 month being off methamphetamines and then 14 months off of methamphetamines. You see that some of that brain, some areas of the brain are starting to recover, others look a little bit worse. Now we're going to shift gears a little bit to talk about traumatic brain injury and chronic traumatic encephalopathy. PET-CT and PET-MR play a vital role in evaluating TBI. It detects brain abnormalities, assesses the extent of TBI, and monitors treatment efficacy. FDG is used to evaluate the metabolic function, and amyloid and tau imaging can also be used to look at the protein accumulation and CTE or repeated TBI, or assess the changes over time. Traumatic brain injury is described as trauma to the scalp, skull, or brain that disrupts the normal function of the brain. It may be a bump, a jolt to the head, or a penetrating injury, and it can be mild or severe. It is important to differentiate between concussion and TBI. Causes of traumatic brain injury most commonly are motor vehicle accidents, firearm-related injuries, assaults or child abuse, sports-related injuries, falls, and recreational accidents. The initial injury could cause a massive hemorrhage or shock, brain herniation, or hypoxic ischemic damage. Long term, this could lead to multi-system failure, confusion, and memory loss. Complications of traumatic brain injury include oxygen and perfusion impairment, metabolic disturbances, edema, and inflammation, and evaluation of intracranial pressure. CTE, on the other hand, is a progressive neurodegenerative disease affecting people who have suffered several concussions and traumatic brain injuries. Symptoms include behavioral problems, aggression, impulsivity, emotional instability, mood problems, cognitive impairment, confusion, violent or suicidal thoughts or behaviors, Parkinsonian movements, and difficulty with gait or balance. CTE progressively gets worse and may result in dementia. There are two forms of CTE. Early onset occurs in the 20s or 30s with mental health and behavioral issues, impulsivity, aggression, and depression. With a late onset around 60, these patients have memory and cognitive issues, dementia, Parkinsonian movements, and it is progressively more degenerative at that point. This is an example of TBI imaging with the Pittsburgh compound. So beta amyloid imaging can be used in this way. There's no control, or the control patient is somebody who has not had a traumatic brain injury. And then the middle ones there are traumatic brain injuries within the first 48 hours and 2 months, roughly, of the TBI. And then the last one is about just under a year after the traumatic brain injury. This is an example of FDG brain where the patient had PTSD. In A and B, the patient has a traumatic brain injury. And then in C, it's a patient who has both PTSD and traumatic brain injury. And you can see where the arrows are pointing to alterations of the normal brain metabolism. This slide is showing comparison of a control of a 35-year-old versus an NFL player who has had multiple concussions and traumatic brain injuries. This is an example of how tau can also be used to study CTE. Although this is not widely accepted, this is an emerging science with all of these rare and emerging neurologic applications. But this is a patient who has had multiple injuries, and the tau protein is being used to assess any kind of chronic damage that has occurred. And you can see that any accumulation of the tau is abnormal. So the last one that I want to talk about is neurocriminology. And this is the use of PET, functional MRI, and SPECT imaging to evaluate brain structure and metabolism. People who have had strokes, epilepsy, traumatic brain injury, or altered function and metabolism can result in cognitive changes that increase their risk of criminal or violent behaviors. In this case, we correlate images with genetic factors, behaviors, and psychophysiology. There are critical implications for different research topics such as ethics, health, law, morality, and philosophy. Neurocriminology is an emerging subdiscipline of biocriminology and criminology that applies brain imaging techniques to the principles of neuroscience to understand, predict, and even prevent crime. This is the case. The images that you see here are scans of a normal brain on the left, and then beside it on the right is the brain of murderer Antonio Bustamante. And he was actually spared the death penalty after the jury was shown these images. Bustamante was a well-behaved teenager, and then suddenly at the age of 22, he became a career criminal. His crimes included theft, breaking and entering, drug offenses, and even robbery. In 1990, he was charged with homicide. The defense team discovered that the client had suffered head injuries from a crowbar at the age of 20, which kind of triggered the onset of his criminal behavior. So his behavior changed fundamentally after that, transforming him from a normal individual into an impulsive and emotionally driven criminal. So the defense team had the client's brain scanned, which revealed malfunctioning frontal lobes. Remember, I told you earlier that frontal lobes and the prefrontal cortex have a lot to do with impulsivity and behavior. So that kind of explains it right there. But at the end, the jury believed that his brain was not normal and they spared him the death penalty. It changed the course of how he was treated as a criminal and the kind of sentence that he received. Some scientists do propose using brain imaging to help decide which soon to be released offenders are at a greater risk for reoffending. And brain imaging data will be used along with common factors like age, prior arrest, marital status, all of the behaviors and interactions, or interpersonal relationships, that kind of thing. And in 2013, there was actually a professor at the University of New Mexico who was studying a population of almost 100 male offenders in the state's prisons. And he found that offenders with low activity in the anterior cingulate cortex were twice as likely to commit an offense in the 4 years after their release than those who had high activity in that area. There was a similar study that was conducted showing that smaller amygdala are 3 times more likely to commit violence crime after their release. So cases like this bring up a lot of questions on ethics and accountability and people's freedom to choose. And it's interesting because you may have a person with the similar brain scan to the one that you see on the right here, but that person doesn't choose to commit crimes. And so there's a lot of ethical questions and things like that that have to be sorted out before the adoption of this becomes mainstream. But it is becoming to be used more and more regularly. There's also a couple criminal defense cases and where it will show you kind of the healthy versus unhealthy brains. And as you can see here, there are 3 healthy controls, and then, or the healthy control images, and then somebody who has affective psychosis versus non-affective psychosis. And you can see in each one, the metabolism of the brain changes slightly. And again, this is little bit lower quality image showing psychosis and how that changes from the uptake in a normal brain. So in summary, there are a lot of other applications to PET neurologic imaging for neurocriminology, mental health, and behavior health that are still being developed. Interpretation for many of these conditions is very complex. PET-CT and PET-MR have the ability to see function and structure, and that holds a lot of potential for future applications for imaging. And I hope you enjoyed that presentation, and thank you for watching.